This is Mark Bigder. I'll be discussing surgical and radiosurgical management of grade 4 and 5 arteriovenous malformations by Mark Bigder, Stephen Chang, and Gary Steinberg of the Department of Neurosurgery, Stanford University School of Medicine. The objectives for this talk are to understand natural history and hemorrhage risk associated with grade 4 and 5 AVMs, review clinical findings, discuss the diagnostic workup, discuss the challenges of decision-making and treatment of high-grade AVMs. We'll discuss our management algorithm at Stanford as well as multimodal approach to AVM treatment. I'll talk about the operative adjuncts and techniques used in surgery, clinical outcomes, as well as pearls for complication avoidance. AVMs have initial hemorrhage rates of 2 to 4% per year. Rebleed rates are approximately 4 to 18% per year. Hemorrhage-related mortality ranges from 10 to 15%, while 15% of patients who suffer from AVM hemorrhage experience a neurological deficit. Morbidity rates tend to be higher for grade 4 and 5 lesions due to large size and proximity to eloquent structures. Grade 4 and 5 AVMs tend to be larger lesions, therefore often present differently than smaller AVMs. Patients harboring high-grade AVMs may present with seizure, headache, and hemorrhage, but may also present with transient and/or progressive neurological deficits as a result of associated cerebrovascular steal. High-grade AVMs are more likely to involve eloquent cortex, have decreased radiosurgical cure rate, have higher complication rates. Some have suggested that partial treatment may worsen natural history, although this has not been our experience in our studies. In terms of evaluating AVMs, all of these patients will undergo digital subtraction angiography. We include bilateral internal and external carotid, as well as vertebral artery injections. This allows for visualization of arterial feeders, size and configuration of the AVM, as well as number and direction of draining veins. We obtain MRI in all of these patients. This allows us to demonstrate the relationship of the AVM to critical structures, allows for three-dimensional reconstruction of the AVM nidus, as well as surrounding white matter tracts. We often employ functional MRI and DTI, which can be useful to identify eloquent areas and tracts of the brain. And we also find MRI useful as it allows us to visualize any surrounding hematoma. This is the management algorithm we think about when discussing treatment of high-grade AVMs. The first consideration is whether the AVM has ruptured or not. In cases of ruptured AVM, we typically will evacuate any significant hematoma if it's causing mass effect on the brain, and then treat the AVM in a delayed fashion. We do, however, treat any high-risk features such as any aneurysms that may be present in the acute setting. Once the patient is managed acutely, we then defer treatment of the AVM to usually a later date. We then consider staged embolization of main arterial feeders, as well as staged stereotactic radiosurgery in an attempt to downgrade the AVM. Once this is done, we often wait for a period of time. This can be up to 3 to 4 years in cases of radiated AVMs, and then plan for a staged or single-session surgical resection. In cases of non-ruptured AVMs, the main considerations are patient age and whether the lesion is symptomatic or not. Generally, if a patient is greater than 60 years old, we'll favor conservative management. If the patient is less than 60 years old, we consider whether the patient is symptomatic or not. In cases of symptomatic AVMs, we will most likely treat the patient. However, if the patient is asymptomatic and over the age of 40, we'll again favor conservative management. In younger patients who are also asymptomatic, we will consider treatment given the increased benefit to risk profile and the associated lifetime risk of AVM rupture. Endovascular embolization, in our opinion, is not effective as a standalone curative therapy for high-grade AVMs. It is, however, very useful in reducing volume and flow in AVMs and downgrading the lesion grade prior to stereotactic radiosurgery and or microsurgical resection. This is often performed in stages to allow gradual reduction in flow hemodynamics. Attempts to embolize large portions of an AVM in a single stage are often complicated by increased risk of hemorrhage. Stereotactic radiosurgery has established itself as a successful treatment for small to moderate-sized AVMs, particularly in critical brain regions. Similarly, with endovascular embolization, we do not consider stereotactic radiosurgery as an effective tool for single therapy for large AVMs. Risk of radiation-induced complications increases with larger AVMs. Obliteration rates are generally low for grade 4 and 5 lesions. We again consider this adjunctive treatment rather than curative for large AVMs. In terms of special perioperative adjuncts and techniques, we employ intraoperative electrophysiological monitoring in nearly all cases. This involves bilateral somatosensory evoked potentials as well as motor evoked potentials and brainstem auditory evoked potentials where appropriate. This allows for early detection of excessive retraction, manipulation of critical structures, excessive hypotension, or compromise of critical non-feeding arteries. We use frameless image-guided navigation for almost all cases, and this can include DTI tractography and or functional MRI, depending on the case. We use radiolucent cranial fixation, which allows for an intraoperative angiogram to confirm obliteration after surgery. We routinely employ mild hypothermia for neuroprotection with a core body temperature of 34 degrees Celsius. We use intraoperative quantitative and directional blood flow measurements with a flow meter throughout the case, which allows us to assess flow of vessels to and from the nidus. In terms of clinical outcomes, Chang et al. Reported a series on 53 patients treating grade 4 and 5 AVMs. Among patients who completed multimodal treatment, 58% of these had an angiographic cure. Nataraj et al. Reported cure rates of 84% for grade 4 lesions and 53% for grade 5 lesions. Steinberg et al. Reported successful treatment in 93% of grade 4 lesions. In this group, excellent results were obtained in 56% and good results in 37%. Good results were also found among 75% of patients with grade 5 lesions. Focusing on complication avoidance, one of the most devastating complications of resection of AVMs is postoperative hemorrhage, and this can be due to inadequate hemostasis, failure to completely resect the AVM, or to normal perfusion pressure breakthrough. Strategies to reduce risk of hemorrhage include careful inspection and hemostasis of the resection bed after removal of the AVM for a short period of time. While we're inspecting the cavity, we raise the maps above the planned postoperative parameters to ensure there's no bleeding. We use intraoperative digital subtraction angiography and image-guided navigational systems, which allow us to confirm the extent of our resection. We use postoperative hypotension with a MAP goal of 60 to 65, typically in the ICU for 1 to 2 days, to permit adjustment of the cerebral vasculature to the new hemodynamics. Normal perfusion pressure breakthrough can be minimized by staging surgical procedures to allow gradual change in cortical vasculature, flow dynamics after each procedure, followed by several days of deliberate hypotension after final resection of the AVM. Hemorrhage also occurs after embolization of AVMs and occasionally requires emergency craniotomy to remove blood clots. Risk of hemorrhage is reduced by staging the embolization procedure, embolizing less than 30% of the AVM at any single session, and maintenance of a 12-hour period of relative hypotension after the procedure. Sudden reduction of flow in the enlarged draining veins can predispose to venous thrombosis. This can result in parenchymal swelling, hemorrhage, and severe neurological deficit. One strategy we use to try to reduce this is to avoid fluid restriction postoperatively. Hydrocephalus can result due to intraventricular blood. This can be from the initial hemorrhage, in which case we try to remove the blood if possible. Meticulous hemostasis should be maintained throughout the procedure and try to minimize any acute ventricular blood. If there is significant intraventricular blood and we're not able to remove it, we'll typically use a ventriculostomy prior to closure. Ischemia is a complication which can occur to inadvertent sacrifice of arteries that normally supply the cortex. We're very careful to preserve en passage arteries during the resection. In a series of patients undergoing embolization, it has been shown that incidences of approximately 10% for transient neurological deficits and up to 6% for permanent neurological disorders can occur. In summary, many grade 4 and 5 AVMs can be treated safely with current technology. Optimal patient outcomes often require multimodal therapy consisting of preoperative embolization, stereotactic radiosurgery, followed by meticulous microsurgical resection and perioperative management.